Objective is the article is discuss the mechanical ventilation strategies used during cardiothoracic surgery for lung protection for stress-induced damage.
Elena Vignan. She is the science director of number research project in the anesthesiology sector and winner of several national and international scholarships. Francesco Saglietti, Division of Anesthesiology, Critical Care and Pain Medicine, Department of Medicine of Surgery, University of Parma, Italy. Antonio Di Lullo, Department de Anesthesia of Intensive Care, IRCCS, San Rafael Scientific Institute, Milan, Italy.
It is evidential that is the article on the management of mechanic ventilation during cardiothoracic surgery and the subject consultation as a close relation that is based of professional practice when knowing that such medical ventilation as a relation between circulatory system and the use of technique to prevent lung complication.
Mechanical ventilation is a technique used to support the patient breathing during surgery in which the anesthesiologist subject the patient to cardiothoracic anesthesia, in which the thorax is open, in which there may be complication, which may be a mechanical deteriorate of the extension thoracic presence of the post-therapy pain, where breathing is affected, decrease the protective cough reflex and increase in post-therapy pulmonary complication nerve injuries such as phrenic nerve palsy which directly affected the function of the diaphragm. Injures to the intercostal nerve causing neuropathy in terms of pulmonary complication due to period are respiratory infection, respiratory failure, pleural effusion, atelectasis, pneumothorax, bronchospasm, and aspiration pneumonitis. For patients undergoing cardiac surgery, like tidal volumes are journal used to minimize the risks of atelectasis and low PEEP levels are stabilizations to minimize the hemodynamic impact in which there is currently more evidence of the of the projectile low ventilation with
In the contribution of the new collage, it should be taken into account that the particularities of mechanical ventilation in cardiothoracic surgery are sternotomy and sternosynthesis, which is where change in lung elasticity occur, nerve damage, and ventilatory dysfunction, which is where diaphragmatic function can be affected. On the other hand, protective ventilation in patients undergoing cardiac surgery is generally programmed with high volumes, this 10 of 12 milliliters per kilograms, to minimize atelectasis, and low PEEP levels are stabilized to minimize hemodynamic impact. Protective ventilation should be considered since it avoids the rise of postoperative pulmonary complications, and at the cardiovascular level, it reduces venous return and cardiac output. Finally, the parameters to be programmed are moderate tidal volume for 6 for 8 ml out kilogram of the idle web, PEEP 2 and 5 CmH2O, the FIO dose 18 for Shun, mood CPAP, and respiratory rate 15 and 20 RPM.
We continue with question based on the objectives. Number 1. What perioperative pulmonary complication can be generated in cardiothoracic surgery? Number 2. What are the degrees of anemia and from what value does in the required transfusion? Number 3. What is acute lung injury relative to transfusion? Number 4. What are the parameters to be taken into account for projective ventilation during cardiac surgery? Number 5. How can cardiopulmonary bypass cause lung damage? Number 6. What are the adverse effects of one lung ventilation?
Conclusion in the practical scenario, the sternotomy is an incision in the sternum to up the recay and perform open heart surgery. This surgery is performed with open or closed pleura. In case it is performed with pleurotomy, there is increase in the elastance of the chest wall and decrease in pulmonary elastance, therefore complication such as mechanical deterioration of chest expansion and the presence of postoperator pain can occur affecting the patient's adequate breathing. Phrenic nerve injury can be a complication that can occur in cardiac surgeries, which will directly affect the function of the diaphragm. Blood flow through the cardiopulmonary bypass circuit releases inflammatory cytokines that cause lung damage, by increasing the permeability of the interstices. In addition, the volume overload, the incidence of interstice edema, and consequently atelects increase. On-loop ventilation is an important ventilator technique in cardiovascular surgery because it allows the removal of pathology. This from a lung while maintaining an adequate level of oxygenation in the other. However, there are factors that affecting such as at the lateral position of the patient during surgery that leads the gravity dependent increase of perfusion to the ventilated lung. Protective ventilation in cardiac surgery should be considered with there are pulmonary disease, prolonged anesthesia of or surgical patients at high risk of postoperative complication. High tidal volumes are generally used to minimize atelectasis, and PEEP levels are zero to minimize hemodynamic impact.
Continuation, it will talk about simple conceptual map. Managing mechanic ventilation during cardiothoracic surgery and open